Welcome back, everyone. We are going to go ahead and get started. I'd like to thank all of you for being on time. If you are joining us for the first time today, we have an afternoon plan that includes polling, session evaluations, and CMS experts that are going to share their experiences and knowledge with you. If you have not reviewed the polling instructions, please review the participant instruction document that is posted on the CTEO website. The link was emailed to you yesterday. Also note that if you have questions for presenters, you can send those in anytime throughout the day to the SurveyMonkey link that is also on the CTEO website. Eligibility for PACE includes specific basic requirements. Our next speaker will discuss the state roles and responsibilities related to PACE eligibility, the interface between the PACE organizations and the state as it relates to eligibility requirements, and the various components related to the determination of continued eligibility. It is my pleasure to introduce to you Cindy Proper.
Thank you, Stacy. As she said, I'm Cindy Proper, and Carrie Smith and I work on the Medicaid side of the house here at CMS Central Office, which is a layman definition for the long organizational title that you see on the screen. So we're really excited to be here this afternoon to talk with you about state roles and responsibilities related to PACE eligibility. And you might be thinking, why would we pick PACE eligibility as a conference topic? It's pretty cut and dry. And you would be correct. I mean, the PACE reg pretty clearly defines what eligibility requirements are for PACE. But we do often see some confusion related to state roles, PACE organization roles, and even some of the areas related to continued eligibility. So we thought it would be helpful today to just walk through some of that. So hopefully you'll find it informative. I have about 12.5 slides that I'm going to walk through, and then Carrie and I will be happy to answer any questions that you may have. Since most of us in this room work in the PACE world, I'm sure you're quite familiar with the basic eligibility requirements for PACE, as described at 460-150B. Individuals must be 55 and over, determined by the state to meet the state's nursing facility level of care, and reside in a CMS-approved service area for the PACE organization, which will be defined in your three-way program agreement and will also be included in the HPMS system. So the basic eligibility requirements are pretty cut and dry. Age, you are the age you are, residing in the service area, you live where you live, and then the individual must also be determined to meet the state eligibility requirements for nursing facility level of care. So let's talk briefly about nursing facility level of care. The level of care determination process itself can vary operationally across states. I'm sure those of you that are in organizations that are in multiple states probably have seen that. But it's ultimately the state's responsibility to ensure that individuals enrolling in PACE meet the level of care for that state. And just a couple of notes, we're aware that some states do delegate part of that determination process to PACE organizations. Some states use their local area agencies on aging to conduct the level of care assessment, and other states may use separate state staff in their PACE area to make those determinations. But regardless of how the process is structured in your state, just a reminder that the level of care determination process is required for all PACE participants, not just those that are Medicaid eligible or are applying to become Medicaid eligible. So this is something that CMS relies on the states to determine nursing facility level of care for all PACE participants or prospective PACE participants. Okay, so this is one of the things we wanted to just clarify a little bit. Other eligibility requirements. What's interesting is the reg specifically identifies other eligibility requirements separately than the list of the basic eligibility requirements that we just reviewed. So 460-150C states that at the time of enrollment, an individual must be able to live in a community setting without jeopardizing his or her health or safety. And just a note, the criteria that's used to determine if the individual's health or safety would be jeopardized is developed by the state, and it must be specified in the three-way program agreement. So let's talk just a little bit more about the determination of living safely in the community setting. Again, PACE organizations are required to use the state's criteria when making that determination on whether that organization feels they can safely serve that individual in the community. And the purpose of the criteria is so that the determinations the organization is making aren't arbitrary, that a decision that they're making today on whether an individual is safe is going to be based on the same things that they'll be doing 6 months from now, so that there's no kind of arbitrary decision making depending on who's doing the assessment. So PACE organizations themselves do make the determination, and it would be based on their assessments of a prospective participant. So PACE organizations should have policies and procedures in place that identify what particular team members are conducting those assessments, who is making the ultimate determination of whether that person is safe in the community. Again, the purpose of that policy would be that there is some consistency in how that's being done over time, especially if their determination is going to be that they're not safe in the community. So it's really important to have those processes in place. So here's the important message, and this is kind of what we just wanted to clarify. The only reason a PACE organization can deny enrollment is if the participant's health or safety would be jeopardized by living in a community setting. So I'm just going to say that again. The only reason a PACE organization can deny enrollment is if the participant's health or safety would be jeopardized. And the reason I reiterate that is when we're reviewing sometimes new organization policies and procedures, there does seem to be some confusion at times. So as an example, if a participant is under age 55, if a 50-year-old contacts your organization, is interested in enrolling, or if they don't reside in your service area, or if they don't meet nursing facility level of care, they're ineligible for PACE. They don't meet one of the basic eligibility requirements. So this is important for a couple of reasons, but really, even when you're reporting your enrollment denials to your state, or for quality purposes, or for any reporting purposes, that you're not misclassifying somebody who didn't meet the basic eligibility requirements of age or living in the service area as a denial. Okay, and then this chart, not to beat a dead horse, but might help illustrate this for some of you that are more visually oriented. Again, because this is an area where we do see some confusion. So keep in mind, individuals who don't meet or cannot be safely served in the community are the only individuals who can be denied enrollment. And to quote language from the 2006 preamble to the reg, they use the term screened out due to not meeting basic eligibility requirements. So the takeaway again, I don't think I need to say it again, but the only reason you can deny somebody enrollment is if they're not safe in the community. Otherwise, if they don't meet the basic eligibility requirements, they're ineligible. Okay, now that we have that figured out, let's review the rules of the state and the PACE organization and the determination of whether the individual's able to be safely served in the community. While the PACE organization does conduct the assessments of the participant and they make the determination whether they can serve the individual, the state is ultimately responsible for oversight of that process. It's the state's responsibility to establish criteria, I mentioned before, that the PACE organization would use in assessing the individual. And then the state should also have a process in place to provide oversight of the PACE organization's administration of that criteria and how they're making decisions on the denials. That state process actually needs to be included with a new application as part of their state assurance pages. They describe to us how they're going to oversee that process. So some states, most states I would say, oversee the process by reviewing documentation retrospectively of individuals who were denied enrollment. So they'll ask for, who was denied enrollment, and look at the record and kind of make a determination retrospectively that you are doing that consistent with the criteria. We're also aware that some states actually require prior state approval before an individual's denied enrollment. I don't think there are as many as those, but that's at the state's discretion. So again, in summary, the criteria for making this determination are specified in the program agreement, and the PACE organization should be making that determination based on those criteria. Okay, now let's talk about the denial. So the state established the criteria, the PACE organization conducted their assessments of the prospective participant based on that criteria, and they've determined that they are not able to safely serve that individual in the community. The next step would be to propose to deny enrollment to that participant. So the reg clearly requires that the PACE organization notify the individual in writing and include the specific reason. And the reason I mention specific reason is the written notification should say something more than we're denying you enrollment because we don't feel we can safely serve you in the community. Ideally, it will give more detail so that they clearly understand why they're not able to enroll in PACE. The letter should also refer the individual to any alternate resources that might be appropriate. And always maintain supporting documentation of the assessments, the reason for the denial letter, et cetera. I mentioned before that the state has responsibility for overseeing this process, and they can't do it if they don't have anything to look at. We do anticipate there will be legitimate reasons for PACE organizations to deny enrollment because they feel they can't serve the individuals safely in the community. It's just important that it be well documented and maintained, and that it be a formal process. It shouldn't be just a side conversation. An assessor goes out and says, wow, we just don't feel we can safely maintain you, so sorry, you can't enroll. There needs to be that follow through with the written notification, who within your organization did the assessments. You've probably heard the same thing where we routinely hear concerns about possible cherry picking in PACE, and that PACE organizations, are enrolling only the healthiest consumers. So having a robust and clear process for your enrollment denials when they do occur will really help the state, and will help respond to those criticisms as well. Okay, so this is where I wish I would have done a polling question. I wasn't that organized. But so the individuals denied enrollment, can they appeal? So appeals of enrollment denials can be a source of confusion. Sometimes nobody's really sure if they can or where do they appeal. So, because they aren't participants yet. So technically, PACE organization's appeal process wouldn't come into play necessarily because they're not PACE participants. But I want to clarify that denials of enrollment may be appealed by potential participants through the state fair hearing process. And it's applicable for all enrollment denials, regardless of the participant's Medicare or Medicaid status. Medicare does not have an appeal avenue for a PACE enrollment denial, so we do rely on the states to offer that beneficiary protection. Now, that being said, there's nothing that requires that the PACE organization have an internal appeal avenue for enrollment denials, but it is appropriate for PACE organizations to do that if they choose to do so, to appeal their decision that they can't maintain that person in the community. And some PACE organizations do have that built into their appeal systems. Because, perhaps if the individual recognizes what the PACE organization's concerns are, they might be able to bring something to the table to address the organization's concerns that could ultimately potentially result in an enrollment. And just an added note is, while we're talking about appeals, not exactly related, but if during the assessment process the state determines the individual doesn't meet nursing facility level of care, the state will provide an appeal avenue for that because it's the state making the nursing facility level of care determination. So that's kind of outside the purview of the PACE organization. You may want to be in the loop and understand how that's going, but it will really be the state that will provide that appeal. And similarly, if the individual's applying for Medicaid and the state denies their Medicaid application, that appeal information would also be provided by the state. And that's another area that sometimes gets confused in the policies and procedures we read about appeals or eligibility for PACE. This is an easy slide. It's pretty widely recognized, but we do every now and then get a question about eligibility based on Medicare and Medicaid status, so we thought we would just include it to reiterate that eligibility to enroll in PACE is not restricted to an individual who is either a Medicare beneficiary or a Medicaid recipient. So an individual may be, but is not required to be, entitled to Part A, enrolled under Part B, or eligible for Medicaid. And that's very different than a lot of our other managed care products. Many times an individual does have to maintain their B or be eligible for Medicaid. So just to clarify, the way the PACE statute and the reg is written, that there's really no anybody can enroll in PACE as long as they, meet the other eligibility requirements. And just one more reminder, Medicaid eligibility is not an eligibility requirement for PACE. We sometimes see in documents that's listed kind of right under all the other eligibility requirements. Now, granted, someone needs to be either Medicaid eligible or be able to private pay, but it can't be listed as an actual eligibility requirement. It can be in the general vicinity of that language, but it shouldn't be listed. Medicaid eligibility should never be listed as an eligibility requirement for PACE. Okay, that's good. Okay, so now we're going to move on to continued eligibility. We're assuming a participant went through all of that eligibility, they're enrolled. Now that a participant is enrolled, I think everyone knows that their enrollment continues until the participant's death, regardless of changes in health status, unless they voluntarily disenroll or they're involuntarily disenrolled. And just a reminder that once an individual's enrolled, an individual's ability to live safely in the community does not come into play related to continued eligibility. Once they're enrolled and they're no longer safe, then it's the expectation the organization will do whatever they need to do to keep that individual safe in the community or place them in an institutional setting if that's needed. A part of the continued eligibility, the reg requires that at least annually the state must reevaluate whether a participant continues to need the level of care required under the state plan for coverage of nursing facility services. So that's kind of a requirement that's on the state. The process can be done in collaboration with the PACE organization, and it's based on a review of the participant's medical record and plan of care. And documentation of this annual recertification must be retained in the participant's medical record so that if, we want to make sure that that was conducted, there should be evidence of that in the record. So what we really wanted to focus on for continued eligibility is there are two options related to the annual recertification requirement that we wanted to review today, waiving and deeming. For some reason, this gets very, very confusing to people, and especially in new applications, they're sometimes even used together, even though they're two completely different situations that have two completely different outcomes. So we just kind of wanted to walk through each of them today. So let's start with the waiver. For those of you who are around prior to PACE becoming a permanent program under Medicare and a Medicaid state option, there was no requirement for an annual recertification of continued eligibility. There was a one-time determination at the time of enrollment, and then pretty much the individual, other than if there were any Medicaid financial issues that had to be looked at, but there was no level of care determinations. However, when PACE became a permanent program, that requirement was added. And But the regulations also included an option for a state to permanently waive the annual recertification if the state determined that there was no reasonable expectation that a participant would improve. So the referencing the 2006 preamble, it did clarify that the expectation was that the waiver shouldn't be granted until at least the first annual reevaluation. So a participant would have been receiving services for at least a year before the state could permanently waive any future recertifications. Again, documentation regarding that waiver should be included in the medical record, including the rationale behind the reason that they expected no reasonable expectation of improvement. So if the state grants a waiver to permanently waive the annual recertification because they feel there's no reasonable expectation that person will improve, no further annual recertifications are required. So that would be like the final recertification document that would be placed in that medical record. So that's waiving. So now we move to deemed continued eligibility. So with the additional recertification requirement being added when PACE became a permanent program, one of the biggest concerns we heard was that since PACE is so successful at managing a participant's care and keeping them very well managed, that it wouldn't be unexpected that that intense management could actually result in a participant improving to the point where they maybe no longer met the state's nursing facility level of care. So while Sections 1894 and 1934 of the Social Security Act implemented the new recertification requirement, it balanced it with an important beneficiary protection to take into account that a participant's condition could actually improve such that they no longer met the nursing facility level of care solely because of the services that they were receiving under PACE. So in that case, without this deeming option, the individual would have to be disenrolled, they would likely deteriorate and have to re-enroll in PACE. So in order to avoid that disruptive cycling in and out, they did allow for participants to be deemed continued eligible if that it was determined by the state that in the absence of PACE services that they would deteriorate to level of care within 6 months. So you can see that's clearly different than deeming. So again, this determination is made by the state in consultation with the PACE organization based on a review of the medical record and plan of care. So this determination is to deem someone eligible who does not meet nursing facility level of care. It's not a permanent determination, however. It simply deems them eligible to the next annual recertification. So unlike waiving, where you're basically saying we don't expect this person to ever improve, we're waiving future annual recertifications. Deeming is they don't meet level of care, but we think that they would deteriorate within 6 months if we took them out of PACE, so they're deemed eligible until the next reevaluation. And that's where it sometimes gets confused. We've seen language where it said that they were deemed eligible and no further recertifications were required. So just to summarize, waiving the annual recertification process would be for a participant who's pretty frail, and due to their conditions, there's no reasonable expectation that they would improve. So the state's basically saying no further annual recertifications are required. Deeming would apply to a participant who has actually improved their health status to the point they're not eligible, but in the absence of the program, they would be expected to deteriorate, and so they're deemed eligible until the next recertification. So sorry to repeat that again, but just to clarify, because this does seem to be one of the areas where we have confusion. So that actually concludes our presentation. So I'm going to turn it back to Stacy and see if anyone has any questions.
All right, if we have any questions in the audience, please go ahead and step forward to the microphone. Do have some questions here that were received from our virtual audience, and so I will go ahead and ask these questions that we received. The first one: How do we handle non-contracted provider appeals? Do they have external appeal rights with the IRE?
Okay, can you repeat that?
Sure.
Yep.
How do we handle non-contracted provider appeals? Do they have external appeal rights with the IRE?
Okay, so the answer to the question is they don't, and you chime in if you understood it differently.
Okay.
So if we're talking specifically about eligibility, if the PACE organization is denying enrollment, there is no Medicare appeal process for enrollment denials in PACE. There is definitely a state appeal option. I'm not sure what the person meant by contracted
Yeah, I think they
appeals.
might be confusing the eligibility appeal process with maybe a denial of service appeal process, which is different and not what not what
Yeah.
we're talking about.
Did they
here.
say non-contracted? Or
Non-contracted.
So maybe they're talking about the organization themselves. So PACE organizations, as I said, PACE organizations themselves are not required to specifically in the reg, but they certainly can offer an appeal avenue for an enrollment denial. Because again, it's the organizations that making the determination. So if we didn't answer your question correctly, maybe the person could reword it. Sorry.
Absolutely. That's what I was just going to say, is if that question was not answered, go ahead and send in another and reword it or be a little more specific. Okay, we do have a question in-house. Oh, hang on. Can we have the microphone? Thank you.
Hi, I'm Joanne Lynn from Altarum Institute Center for Elder Care and Advanced Illness. The forcefulness with which you gave the statement that the only reason a person could be excluded was that they couldn't live in the community. Once you get outside of Medicaid, where the person is Medicare only, or even in the rare circumstance where a person really doesn't have either, doesn't have Medicare or Medicaid, they have to pay a piece. So isn't that a reason for exclusion as well if they won't pay?
Well, but at that, the person is not enrolled yet, so you're not going to charge them until they're enrolled, and then they could be, if they don't pay, then they could be disenrolled. But you're not going to exclude them until you give them the chance to enroll, and then if they don't pay.
Oh, I see.
Yeah,
A very technical distinction.
Yeah, and
Okay,
I think it's
got that.
Yeah, and I think because we often sometimes do get the other questions about that, but yeah, it's just you're telling them they cannot enroll, so you're denying enrollment. I think so. Yes.
Okay, the next question that we have here. You said that individuals that don't meet the basic eligibility criteria are ineligible, and that only individuals who are not safe in the community can be denied enrollment. What happens if a prospective participant meets the basic eligibility criteria but decides not to enroll in PACE?
So since this person met the eligibility requirements, we would, and then it was their decision to not enroll, we wouldn't consider that a denial because it was, they still met the criteria if they were able to live safely in the community. We consider that more of like a withdrawal because it was the person's choice. I'm sure you all have folks that come in and for some reason or another decide to go another route, even though they did meet all the eligibility requirements. So that's not really like you denied them, that was their choice to do so.
Okay, thank you. The next question. You referenced that the state should have a process for oversight of the organization's denial of enrollment. Can the state delegate review of denials of enrollment and review of proposed involuntary disenrollments to local departments of social services?
Yes, certainly. Again, states have general oversight responsibilities of those processes, but many states do use either downstream entities or even local entities to perform those functions. So as long as they are using those processes and overseeing those processes, that's acceptable.
Okay, I have another question here. If an individual is living in a nursing facility, does the PO take the individual to the community living arrangement for assessments, and would this be considered living in the community?
Can you repeat that again one more time?
Sure. If an individual is living in a nursing facility, does the PO take the individual to the community living arrangement for assessments, and would this be considered living in the community?
Well, if they're in a nursing home, they're not considered living in the community. The PACE organization can look at resources that they may be able to provide to the person to have them live in the community, and then they would assess, that person, if they were helped to get into the community, whether they were able to safely live in the community once they were in those resources.
Right, and we do get that question from time to time. Do they actually have to be living in the community in order to enroll in PACE? And the way the reg is written is that they have to be determined at the time of enrollment to be able to live safely in a community setting. It doesn't necessarily mean they are living there at that exact moment, but if the PACE, that's a risk the PACE organization takes, but if they do an assessment and feel that that individual is safe in the community, there's nothing to prevent them from enrolling that participant.
Okay, I think we have a question in-house.
Hello, my name is Betsy Canino. I am from Payson, Rhode Island. My question is, most of the participants that come to us, well, not most of them, but many of them, don't look safe when they come to us. So if I was just to look at them, I'd say, that person is not safe in the community. And yet I think I can provide them some services that might make them safer in the community. But I can't guarantee that. I don't know if they'll accept it. I don't know, and that sometimes becomes an issue. Or the other thing that happens is we have someone living with a family member, and a month after they're enrolled in PACE, the family member says, whoops, I can't do this anymore. She's on her own now. She is not safe living in the community by herself, but I don't have 24-hour family services to go and live with her, and yet now she is a PACE participant. And I get a lot of feedback from my staff like, why do we put so many people in nursing homes if we're community-based? And sometimes you just can't step away from it.
So I'll
Do
start.
you have any guidance on those?
So I think that to address your first point, I think that the assessments are critical. We leave it up to the organization about assessing the person to see if they meet those criteria. I think the organizations are in the best position to determine themselves whether they feel like they can provide, with the appropriate services, keep that person in the community without harming themselves. So I think that, over the years, we have seen many challenges that organizations have come across about family members, not doing their part, and that was part of the original plan, and things like that happened. But I know that, with the whole interdisciplinary team, PACE organizations are very creative. They know the resources that they can give these people to be able to help them stay in the community. So I think it's one of the beauties of the program is that there are so many ways to be creative, contacts with connecting services and integrating care to make sure that people get all the services that they need, that PACE organizations are, perfectly set up to be able to do that and deal with those challenges when they arise. Might not happen a month into it, but might happen 2 years later, whenever it does happen. I think PACE organizations are always coming across those challenges, and I think you all are the best ones to be able to do that.
That's good.
Okay, next question. Is a PO able to deny enrollment at any time?
We can try to
Yeah.
understand what that means. After they've done the assessment, I think it's interesting because I think we get that question a lot is, can anybody disenroll at any time? So I think it's...
I'm sorry, I misspoke.
Okay.
Is a PO able to delay enrollment at any time?
Oh.
Does that make more sense?
Well, they're really, I guess we're just kind of, if There's really no specific time frame that we say once a participant contacts a PACE organization, they must be enrolled within such a period of time. So, I mean, in a case certainly like Rhode Island just said, if you aren't sure someone's safe and you're trying to work through some details of whether or not the care team can safely serve that individual, I think it would be appropriate. What I guess we wouldn't want to see is purposely delaying so that you don't have to enroll someone. If you know that you're going to have to deny them, then that process should be followed through to the end. But
Right, and typically the sooner folks get services, the better, right? So they may have had some sort of incident that happened that led them to where they are, and that the sooner they get services, the better. So.
And another example of when sometimes enrollments have been delayed is if they do an assessment, everybody thinks looks good, and 5 days before the effective date of enrollment, the individual goes into the hospital. So obviously, there'll need to be reassessments depending on what the situation was that preempted the hospitalization to make sure that following that, they'll still be able to safely serve them. So that would be another legitimate reason for delaying enrollment.
Okay, now this next one does have the word deny in it. So, can a PACE organization deny enrollment if there are concerns about other participants' safety? For example, a potential participant has a mental health history and has reported hearing voices that tell him to hurt other people. If during the initial assessment of a potential enrollee, the PO provider determines that they do not meet facility LOC, can the PO deny enrollment based on not meeting facility LOC?
So are you saying they didn't meet nursing facility level of care? Hopefully you said that, because that'll make the question really easy.
Yes.
So if
that?
they
Yes.
don't meet nursing facility level of care, that is not a denial of enrollment. That it means they're not meeting the basic eligibility requirement. So the state who denied the nursing facility level of care would issue the prospective participant an option for an appeal to the state's determination of that.
Okay.
And a couple other things too I might add to that, just to add. I think that, the criteria for able to live safely in the community may include things like harming themselves or others. And so if that was part of the criteria that you're using against to see whether somebody's able to live safely in the community, that's an easy thing to point to say, we assessed this and they didn't meet that criteria, and that's why they're not able to live safely in the community.
Good point. Yeah, because we do see that a lot. There's criteria vary too across states. Sometimes there's a big long list, sometimes there's little ones. And we do look at those as part of the application process to make sure that they're legitimate criteria. So.
Okay, that brings an end to the questions for this session. If you have additional questions for these speakers, please go ahead and send them into the SurveyMonkey link, and we can address them later on during the open Q&A session. So thank you to Cindy and Carrie, for sharing with us the roles and responsibilities relating to PACE eligibility. Okay, if you would like to evaluate this session, session number 4, please take out your phones and text your response, or go to the Poll EV link on your iPad, phone, or computer and enter A. And then go ahead and follow the instructions. Just a quick announcement to those of you that are in the audience here. I know that there has been some difficulties with connecting to the internet. There are packets out at registration that give you instructions on how to connect to the internet here. Apparently you have to start all over, is my understanding. So if you do need that, please head out and grab a packet so you can reconnect. Our next speaker will provide participants with an understanding of the programs of all-inclusive care for the elderly change of ownership guidance and notification process. She will also share with you the purpose and process of the PACE Chow. It is my pleasure to introduce you to Kelly Ordonio from the Division of Medicare Advantage Operations.
Good afternoon, everyone. My name is Kelly Ordonio, and I'm with the Division of Medicare Advantage Operations. And I'm here today to speak to you about the PACE change of ownership. And as we speak about the PACE change of ownership, it is referred to as a PACE Chow, just so you're aware of the abbreviation as we move forward. Historically, the change of ownership transactions have not materialized in the PACE program. Within the last year, we have seen more requests from PACE organizations and had states reach out to us to request discussions about these. Okay. To discuss these types of business transactions. CMS is seeing an increase in the Chow activity and recognizes the need to provide additional guidance. And we are working on gathering more information and providing that guidance in the near future. As CMS is receiving more PACE Chow requests based on business decisions of the PACE organizations, we just want to keep in mind the end goal. CMS's ultimate responsibility is to the PACE participants, and our objective is to confirm that the acquiring entity is qualified and financially able to assume the responsibilities under the PACE program agreement. Next, we'll talk about how CMS defines a PACE Chow. CMS defines a PACE Chow as the removal, addition, or substitution of a partner, an asset transfer, meaning a transfer of a title and/or property to another party, or the merger of one PACE organization into another entity, or the consolidation of the PACE organization. PACE Chow transactions. These transactions result in the acquiring entity assuming the acquired PACE organization's responsibilities under the PACE program agreement. And with this, we require an executed novation agreement. An executed novation agreement is an agreement between the current owner of the PACE organization, the acquiring PACE organization, the state administering agency, and CMS. This four-way novation agreement is effective on the proposed effective date stated in the novation agreement, which has been agreed upon by all four parties involved. It will also demonstrate that the acquiring PACE organization has become the successor in interest to the current owner's PACE organization. The HPMS memo dated February 18th, 2016, titled "The Guidance on the Notification Requirements for the PACE Change of Ownership," Attachment B, provides a PACE model novation agreement for PACE organizations to use. Next, we'll discuss some of the PACE Chow requirements. A notification letter must be received by CMS. In the event of a PACE Chow, the current PACE organization must submit its notification letter on organization letterhead to include the contract IDs, required novation documents, and details on the proposed transaction and point of contact. The PACE organization must also include the documents listed in Attachment A and follow the PACE Novation Agreement in Attachment B of the HPMS memo dated February 18th, 2016. Guidance on the notification requirements for the PACE change of ownership with their notification letter. The acquiring entity must meet all requirements to qualify as a PACE organization under 42 CFR Part 460 Subpart B. An entity that is not currently an approved PACE organization, but intends to acquire an existing PACE organization, must use the PACE application process as a means to qualify as a PACE organization within the acquiring service area. The HPMS memo dated December 11th, 2015, titled 2016 PACE Application Guidance, lists out the necessary steps the PACE organization will need to complete and the specific timeframes as to when they need to be completed by. Also in HPMS is the e-PACE Application Industry Training, which was released on February 2nd, 2016, which will provide additional guidance while completing the e-PACE application. The existing PACE org should contact its CMS Regional Office Account Manager for details on how the acquiring entity would qualify through the PACE application process. And the last bullet, the PACE organization must submit all the documents to the DMAO portal at this location. PACE organizations will need to submit their notification letter and documents to the DMAO portal under the CHOW tab. Once all documents are received, CMS will need sufficient time to determine whether the acquiring entity meets statutory and regulatory requirements for entering into a PACE program agreement. If any PACE orgs and/or states have questions about the proposed PACE CHOW request and would like to discuss ahead of submitting your formal request, CMS will gladly assist and engage in those conversations. Next slide. And potential PACE CHOW issues. So the first bullet is uncertainty if a transaction is a CHOW and/or requires a novation. And contact CMS early and often for guidance. We realize that we do have guidance out. However, we do encourage the PACE organizations and the states, if they're aware of or thinking about these types of transactions, to reach out to us and to establish those types of conversations early on so that we can make the process as seamless as possible. Obviously, we've had more in the past year, so we too here at CMS are trying our best to make the process as seamless as possible given all of the different requirements within the states as well. Untimely notification. Failure to submit timely notification may delay review and approval and may result in the program agreement termination. So we just ask that before the PACE organizations start to move forward with these types of transactions, that you please engage CMS so that we are aware and can make sure that not only the federal regulations are followed, but the state regulations as well, to ensure the end result is achieved. Uniformed stakeholders. Any CHOW action requires state and CMS review and approval because the PACE program agreement is a three-way agreement. And once again, we just want to reiterate the collaboration between the states and the PACE organizations and us in moving forward with these types of business transactions that the PACE organizations have decided to engage in. States and CMS may have different requirements related to the CHOWs. So each state may have different requirements when these types of transactions are taking place, and we need to make sure that not only are you following the federal regulations, but that we are able to ensure that all the state regulations are followed as well. And CMS does work very closely with the states and the PACE organizations to achieve the end goal in these types of transactions. And it is much appreciated if you reach out early so we can start to engage and determine the process and the direction that we will be going in. Next slide.
All right, do we have any questions from our in-house audience? Okay, then I do have a question that was sent in that I will ask. Actually, I have two of them here. The first one says, please elaborate on the timeframes related to the CHOW process and how they differ between situations in which the acquiring entity is a PACE organization and those in which it is not.
So CMS has encouraged PACE organizations and/or acquiring entities seeking a PACE CHOW transaction to contact CMS and their state administering agency prior to discuss timeframes and make sure all parties involved are abreast of the requirements, as they can be different amongst the different states.
And then the second question is, please elaborate on those circumstances in which CMS will be using the PACE application process to qualify acquiring entities that are not currently PACE organizations.
Yes, so an entity that is not an approved PACE organization and needs to qualify as a PACE organization in order to acquire a current PACE organization would need to follow CMS's guidance issued on the December 11th, 2015, titled 2016 PACE Application Guidance to become qualified. You can notify your account manager for further assistance, as they will contact us and we can work together through the process.
Okay, any additional questions? Okay, if not at this time, I would like to thank Kelly. Okay, we are going to go ahead and evaluate session number 5 at this time. I think you guys are pros at this now. Go ahead and respond A, follow the directions. All right, we're a little bit ahead of schedule right now. So we're going to go ahead and go to our afternoon break. And one of our goals today is to stay on time as far as when we start sessions. So those that are in our viewing audience can join. If they join at that particular time, they'll get the session that they're looking for. So our afternoon break is scheduled until 2:15, at which time we will come back for the financial considerations session. So we will go to break now, and we will see all of you back here promptly at 2:15 for our next session. And just a reminder, if you have questions, go ahead and send those in. We will also have a survey for the entire day, to evaluate the entire day. At the end of the day, we'll give you that link. So enjoy your break, and we'll see you back here 2:15.
puertorriqueña. Yo te la traigo de Cupey, de Vega Baja y de Santurce, de todas partes de Puerto Rico. Esta bomba yo la dedico a toda mi gente de Puerto Rico, a la familia Fontanet, allá en Cupey Alto y Lo Mejía en Vega Baja. ¡Que gocen! ¡Sí! Bomba, bomba, para siempre. Bomba, bomba está presente, aquí lo canta mi gente. Bomba, bomba, para siempre. Baila, baila y goza, mi bomba puertorriqueña. Bomba, bomba. Bomba, bomba. Bomba, bomba. Bomba, bomba. Bomba, bomba, para siempre.
Welcome back, everyone, to both those here in-house with us and those who are viewing. Thank you for being back on time. Hope you enjoyed that break. I just wanted to go through a couple reminders before we get to the end of the day. And one that is, the first reminder I have is to remember to send in your questions for speakers. We will have the open Q&A session at the end of the day, where we will be answering any questions that you send in that we have not gotten to. Two, for our viewing audience, remember that if you use an Ethernet connection and Google Chrome, that may help to increase the webcast streaming speed and prevent delays. And lastly, you will have an opportunity to evaluate today's conference, and the link will be sent to you after this event ends today, and you will also have an opportunity to complete it via the polling software at the end of the day, so stay tuned for that. Our next speakers will cover CMS's fiscal soundness requirements and the overall reporting and financial review process. In addition, an understanding of the 1/3 financial audits, the audit process, and typical findings will be shared. I am happy to introduce to you Yasmin Galvez and Amando Veratra.
Thank you, Stacy. And I'm on. Yeah. Thank you, Stacy. Good afternoon, everyone. My name is Yasmin Galvez. I work in the Division of Finance and Benefits in the Medicare Contract Administration Group. The purpose of my presentation is to provide you with an overview of the fiscal soundness review for PACE organizations. Okay, it's not working. Next slide. Okay, great. So I will cover CMS's fiscal soundness requirements and the overall reporting and financial review process. So let's have fun. The Division of Finance and Benefits reviews and monitors the fiscal soundness for PACE organizations. Fiscal soundness is the term used to describe the organization condition of to describe the financial condition of an organization. Specifically, a fiscally sound organization maintains a positive net worth and it has an operating surplus. In other words, a positive income. A fiscally sound organization may have a net loss, but that net loss cannot exceed 1/2 of the net worth amount. An essential part of evaluating fiscal soundness is access to timely and accurate financial information. So the Health Plan Management System Fiscal Soundness Module supports CMS' ability to collect, store, and review financial information submitted by PACE organizations. PACE organizations submit the required financial information and the required financial data elements through the fiscal soundness module. Later in my presentation, I will go over the financial documentation and the financial data elements required for each submission. The fiscal soundness module serves as a data repository and supports CMS reviews and monitoring activities. It is important to know that if your organization is receiving emails through the HPMS Fiscal Soundness module, then it must likely indicate either your organization is submitting the financial information late, or there may be a problem with your submission. In a later slide, I will discuss the financial information required to be submitted, and I will provide CMS contact information in case your organization has a question about the emails received. In March of each year, CMS announces the release of the current year fiscal soundness module, along with the fiscal soundness reporting requirements. The gates in HPMS are open to allow the submission of financial statements required for that contract year. And any changes made in their requirements are incorporated into the March release. As part of the CMS fiscal soundness requirement, PACE organization must maintain a fiscally sound operation and must provide CMS the audited financial statements demonstrating a fiscally sound operation. The requirements are defined as the 3 bullet points with an emphasis on the financial provision of total assets greater than total unsubordinated liabilities. In other words, positive net worth. In addition to the CMS fiscal requirements, PACE organizations are required to satisfy their specific state requirements. The financial documents to be submitted and the associated deadlines will be discussed in a later slide. There are 120 PACE organizations contracting with CMS with nearly 36,000 enrollees. 85 organizations are no longer in the trial period for the purpose of fiscal soundness. Later on, I will discuss the trial period. 71 organizations are satisfying CMS fiscal soundness requirements. 14 organizations are not satisfying those requirements. 3 organizations are experiencing a net loss greater than 1/2 of their total net worth, and 11 organizations have a negative net worth. This is a very important slide. The slide represents common questions that we receive regarding legal entity versus parent organization financial submissions. CMS contract with legal entities whose financial statements are evaluated on their own merit. Therefore, all fiscal soundness requirements must be met by the individual legal entity. If a PACE organization is a line of business of a parent organization and audited financial statements are not available at the PACE legal entity, audited financial statement may be provided for the parent organization. However, this is very important. The PACE organization must provide supporting annual financial statements for the corresponding period at the PACE legal entity level. I must report and upload the required financial data elements at the PACE legal entity. As part of filing requirements, all PACE organizations are required to submit audited financial statements. The audited financial statements are due to CMS no later than 180 days after the organization's fiscal year ends. In addition to audited filings, some organizations may be required to submit quarterly financial statements. This applies to organizations operating within their trial period, 3 years. For purpose of fiscal soundness, the trial period ends when CMS has reviewed audited financial statement covering 3 full 12-month financial reporting periods. In other words, CMS will review 3 audited financial statements, and that's how we're going to review 3 audited financial statements, and that's when the trial period ends. After the trial period, CMS may determine that more frequent monitoring and oversight is needed due to fiscal soundness concern. Therefore, those PACE organizations will also be required to submit quarterly financial statements. Quarterly financial statements are due to CMS 45 days after the organization's quarter ending period, and this includes 4 quarters. The fiscal soundness module is located in the Health Plan Management System, and also known as HPMS. On the main menu toolbar, by selecting Monitoring, than fiscal soundness. Since PACE organizations are only required to submit financial information either annually or quarterly, we encourage all PACE plans to review their organization's contact list in HPMS under contract management prior to submitting your financial information. This is very important because CMS uses the contact list when sending correspondence to PACE organizations. This is a visual of the fiscal soundness module. Again, user will navigate in HPMS to monitoring the fiscal soundness. Here's where PACE organizations submit their financial information. They can also view financial data of existing submissions. They can view reports, and they can also access additional guidance such as the fiscal soundness reporting requirements and the plan user guide. The Plan User Guide provides instructions for uploading and submitting financial information. Really good information in this guide. As part of the filing the audited and quarterly financial statement, PACE organization is required to enter the following financial data elements from the corresponding financial statements into the fiscal soundness module: total assets, total liabilities, subordinated debt, net income, and cash flow from operations. So what is subordinated debt? Subordinated debt is defined by CMS as an unsecured debt whose repayment to its parent company ranks after all other debts have been paid when the subsidiary files for bankruptcy. PACE organization that reports subordinated debt must complete an attestation of subordinated debt arrangement form and upload a signed version into the fiscal soundness module and must be included with both annual and quarterly financial statement submissions. The PACE organization of attestation of subordinated debt arrangement form was updated this past at the beginning of the year in 2016 and can be located under the Documents and Forms section of the Fiscal Soundness module in HPMS. For Fiscal Soundness module data entry purposes, if subordinated debt is identified by the PACE organization on the balance sheet, it should be included in the total PACE liabilities, and the amount of subordinated debt should be entered for the subordinated debt financial data element. It is very important that the amount on the attestation form matches the amount entered into the subordinated debt data financial element. I know it's hard to see, but here is the subordinate attestation form. An important note is that the attestation form has to be signed by both the PACE organization legal entity and by the parent organization. This form must be uploaded with your financial statements in the applicable reporting submission period. CMS will calculate the total unsubordinated liabilities by subtracting the subordinated debt amount from the total liabilities prior to making the final fiscal soundness determination. The next two slides identify some things to remember when you are completing your fiscal soundness submission. First, I would like to point out an important guidance document related to fiscal soundness. The fiscal soundness reporting requirement summarizes the overall reporting process and defines deadlines for each organization type. Since reporting requirements vary by organization type, this document is structured into the following categories based on the information that it applies to Medicare Advantage organization, cost plan, prescription drugs plan, and PACE organizations. Since many PACE organizations do not use a calendar year financial reporting cycle, we have included a table to show reporting schedule by fiscal year end date. Next, I would like to remind organizations to review the organizational contact information in contract management section of HPMS. From a fiscal standard perspective, the Chief Financial Officer, the Medicare Compliance Officer, and the financial reporting contacts must be up to date in the event CMS needs to contact organizational personnel. In addition, please verify that the accounting fiscal year end information in contract management is accurate. Lastly, based on some of the submission errors that have occurred, please remember the following. Enter total assets and total liabilities, not the current portion. Enter year-to-date net income and cash flow from operations. Enter cash flow from operations, not net change in cash. And if entering subordinated debt, please make sure that the amount matches both the financial data field and the form. There are also a couple of reminders on the next slide related to uploading the financial documentation. Please remember to include the balance sheet, the income statement, the statement of cash flow, and the subordinated debt attestation form if applicable. Lastly, if the organization needs to resubmit and delete a previously uploaded file, then all of the documents need to be uploaded again. This slide highlights the key fiscal soundness regulation for PACE organization, 46080, 46200, and 46208. This slide highlights the key resources related to PACE fiscal soundness requirements. These resources can be found by navigating to HPMS, monitoring fiscal soundness documents and forms. The first one is the fiscal soundness reporting requirement. The purpose of this document is to summarize the overall reporting process and define deadlines and information for each organization type. The clarification of fiscal soundness requirement, this memo was issued last November, and the purpose of this memorandum is to clarify the fiscal soundness requirements for Medicare Advantage organization, for cost plan, prescription drug plans, and PACE organization that contract with CMS. The annual verification of parent organization and legal entity name, that memo was issued last February, and all current and prospective PACE organizations were requested to review the company's parent organization and legal entity names as listed in HPMS, and to report any necessary correction by March. However, if you still have questions related to the parent organization and the legal entity names, please refer to this document for contact information. The PACE subordinated debt attestation form, once again, if subordinated debt applies to your organization, please obtain the form from the fiscal soundness module for each reporting submission to make sure you're using the updated form. As I said before, we updated that form for contract year 2016. The next one is the plan user guide. This resource guide provides instruction for uploading and for submitting financial documentation. And finally, the CMS point of contacts are listed on this slide for questions that might arise. You can also contact me at Jasmine Galvez at cms.hhs.gov. Thank you. Oops. I think I went too fast. I'm not sure. Yeah, she's coming.
Somehow we got to the beginning of your presentation.
And
All set? Oh, yeah, I'm ready. Okay. Go on.
All right, hello everyone. My name is Armando Verada. I'm one of the auditors here at CMS. I work for the Office of Financial Management, and the specific division that I work for is the Division of Capitated Plan Audits. And we are responsible for what I'm hearing is the dreaded one-third financial audits. All right, there we go. We do have a couple objectives today. Hopefully, as a result of the presentation, you will obtain an understanding of the one-third financial audit process. Hopefully, you'll gather some useful information for a successful audit from start to finish. And hopefully, you'll learn about a couple of different types of audit findings that we've encountered with some PACE plans. So why is CMS doing these audits? We know that everybody loves to be audited. Not really. I can tell you from my experience in auditing, people have totally crazy reactions sometimes. We can ask normal questions like, can you explain how you pay a PDE claim or a prescription claim, and people start sweating profusely. Or can I have a copy of a blank enrollment form, and hands are shaking. Those are normal reactions. And then we become, take our auditor hat off and we become a therapist then, and we calm everybody down. But we have encountered some extreme reactions in my career. I guess there was one case I was trying to go over terms of a contract, and we were in a conference room. And I started asking some questions, and then the respondent just says, "I'm not answering anything. I am invoking my Fifth Amendment right against self-incrimination." So please, if our auditors ask you for your terms of any contracts you have with your pharmacies, please do not invoke the Fifth Amendment. Right. One last example. I was auditing a local entity, a government entity, and I went out to a satellite office, wrapped up my work, came out to my car, and I noticed that some things were missing from my car. I had like half of a windshield wiper, the front and the back. My side view mirror was gone, so I went back inside, talked to management. They said, "Well, we have our own police force, so please, you need to file a report." So I talked to the officer. He's asking me, "You have any fights with anybody, any conflicts, any arguments?" I'm like, "No." And I kid you not, then he asked me, "Are you sleeping with anybody's wife?" I was like, "Well, not beside my own," but so then he says, "I see you have a contractor's badge on." I was like, "Yeah, I'm not a full-time employee here. I'm the auditor." And then a light bulb went off. Like, that's why. Because they said it wasn't targeted. They said it was targeted. It wasn't a random kid. They said it looked pretty targeted. So I understand how people react to audits, and we're not doing these audits because we just want to torture you guys. And I have learned that if I'm visiting an audit site, I do not drive my personal car anymore. I'll take mass transit. No, the audits are required by the Social Security Act, which was passed by Congress. And if you care to look up the regulation, it's at 42 CFR. We are required to audit at least 1/3 of all Part D drug plans. There was a waiver in place for PACE plans to be excluded from the audits. That waiver has ended. So now you guys are also subject to the 1/3 financial audits. And just a little FYI, the Medicare Part C and D, which is what we cover in the 1/3 financial audits, that program we pay roughly like $200 billion a year. So we really have to maintain accountability over those two programs. Let's see. All right, the next two slides I'll go over will cover our audit objectives, pretty much what we look at during the audits, and the results that you can receive from the audits. We basically look at the accuracy of the drug claims that you submit, which we call PDEs. We also look at direct and indirect remuneration, which is more commonly associated with drug manufacturer rebates. And we also look at the base year experience reported on the Part D bid, and that is drug and administrative cost. And this is important to us, or these two items are important because this drives the amount that we pay and also the amount of your Part D payment for each month. Also, we look at just your basic internal controls over the payments that you make on behalf of the beneficiaries. And all those solvency requirements that Yasmin mentioned, during our audits, we will also verify that those solvency requirements were met. All right, as a result of the audits, you can receive four different types of opinions. The first is unqualified. That's a clean audit. That's what everybody wants to receive. There are pretty much no formal follow-up actions after the audit. There are no findings. There may be what we call observations, and those are less significant issues which we leave up to management to address. And if there's any errors, we do ask that those are corrected. But those are left up to management to address internally. A qualified opinion is pretty similar to a clean audit. It's basically you have a clean audit except we've identified a couple issues or issue or two. And as a result of a qualified opinion, you will be asked to submit a corrective action plan to CMS after the audit. The last two items, adverse and scope disclaimer. Adverse is basically an example of adverse is we looked at your prescription drug claims, and there was a flaw in the logic that you pay, and pretty much every claim was processed incorrectly. So that would require significant follow-up action and may actually require additional audit after the first audit. A scope disclaimer, an example of a scope disclaimer is our auditors came out. They tried to get information, and for some reason all the records were lost, and the auditors just could not issue an opinion. And then that would require additional follow-up as well. So you'll see on the next slide, we gave a little bit of historical content of the audit results. This is for other Part C and D programs over a 7-year period. As you can see at the beginning of our audits, we did have a good number. The first couple years, we're at 40, 50, 60% of qualified opinions, and the number of unqualified is roughly around a third. And then after the first round of audits, after issues are identified and corrective actions can be taken, the audit results improved to almost 50 and now recently up to like 60%. So we do expect the same type of results for PACE programs. We understand this is your first round of audits and your first upcoming audits. So we do expect some issues to be identified the first couple years, and then after those issues can be resolved, we do expect the audit results to improve. All right, the next couple slides, I'll just try to familiarize you guys with the audit process, just so if you get that email saying you've been selected for an audit, you're not freaking out. So how do we select plans for audit? True to our name and to the regulations, we have to select at least 1/3, but we just don't pick 1/3, 1/3, 1/3. We also look at the membership, enrollment, the amount of payments, also any audit referrals. If there's any significant risk issues, we take that into consideration as well. I'd say at least a couple months before the audit is to begin, you will receive an email notification through HPMS letting you know that you've been selected for audit. That's your first notification. You then will receive another email letting you know which CPA firm we selected to conduct the audit. And that way, when the auditors contact you, you know that this CPA firm was selected by CMS. In that second email, you will also be given a CMS point of contact. Just in case you have any questions, you can contact CMS directly. So after the second email, CPA firms will contact you and let you know. They'll start coordinating the audit. They'll also submit an initial document request list. They'll start scheduling time frames, and at this time it's pretty flexible. So, and we're still talking maybe a couple of months out. And I listed, I'm not going to read everything, but I listed some of the documents that they request, copies of procedures, policies. Also at this time, the CPA firms we already have the PDE data and some of the test samples, so we will provide test samples to you early on, and we'll ask that documentation to start to be gathered and submitted to CMS. And this is extremely important, especially if any PACE plans have any PBMs or pharmacy benefit managers. The greater amount of documentation provided early on will just make the audit go quicker and more efficient. So that's an important piece. All right. Here's a couple other information. You will be asked to sign an assertion letter, basically just to say that all the data you submitted to CMS is accurate and correct to the best of your knowledge and belief. Our auditors will conduct a site visit and have a formal entrance conference. And CMS will normally be on the phone on that entrance conference as well. At that time, if all the documentation was submitted, it's really not really much for the auditors to do on site, a couple wrap-up issues, or if there's a number of issues, they will try to resolve any outstanding issues at that time. And then from about 60 days from the entrance conference, we will have a formal exit conference. And it's very important. During this time, the auditors should let you know if there's any issues or any missing documentation, or if they believe they have some errors. If there's any disagreements, we want to try to work everything out in the field while we're there or before the report is issued. So please, a CMS representative will be on the phone for the exit conference. And please, at this time, if you know you're disagreeing with an issue, please let us know so we can try to resolve that early on as possible. It just speeds up the entire process. And approximately 30 days after the exit conference, the auditors issue a draft report to CMS, and we review it. You will be also asked to formally respond to any audit findings or observations with an agree-disagree letter. And you're also asked to sign a management representation letter. This is a very basic letter. It just says that you've given everything that you've asked for. You haven't withheld anything. There's no known frauds that occurred from the start of the audit to the end of the audit. This is a very basic letter. And then once all that information all those documents are then combined with the draft report, and we will issue a final audit report. And you will receive an email notification in HPMS that your audit report is available for download. Now I'll go back. That email notification also will tell you about any follow-up actions that's required. And I briefly mentioned this earlier on, but again, if there's any unqualified audits, there's pretty much no follow-up actions. That's what everybody wants. If there's a qualified audit, you will be asked to submit a corrective action plan, I believe within 90 days. And you're also asked to correct any errors, especially PDE or DIR reporting errors. And then any observations are required. We ask that you correct those internally. And if there is an adverse or a scope disclaimer, those basically we will contact you separately. Those are handled on a case-by-case basis, and we will contact you individually on those items. All right. We have a quick polling question. Are your NPA or National PACE Association dues allowable cost on the Medicare Part D bid? Wow. Is that it? Oh, there we go. Yeah.
I think it's getting worse. I know.
Okay. It looks like we asked this question because it can be a little tricky. The answer is, or the best answer would be C, some. Technically, A is correct and B is correct, but C is the preferred answer. And right, yeah, that's no. And the reason is that you're like a lot of professional association, the dues cover a portion of lobbying, and government funds cannot be used for lobbying. So the lobbying portion of your dues must be removed from the bids. So there we go. And that's a good lead into some of the audit findings. As I mentioned on the second bullet point, unallowable non-benefit expenses on the bid would be lobbying costs. Also, other administrative expenses for other lines of business that are not Part D related. We also identified some PDE errors or drug claim errors, duplicates. We also identified, seemed like refills are being processed too soon, maybe like a prescription is filled, and then like 3 or 4 days later, another 30-day supply is filled. So those are some issues that have come up. Also, claiming Part A or Part B drugs on the Part D program. Those are some issues. Also, please be careful with pharmacy dispensing fees. I know that some PACE plans have in-house pharmacies. We've seen some issues with maybe some confusion or misunderstanding with administering the drug to the patients versus a pharmacy dispensing the prescription. Also, a recent memo came out, a reminder from HPMS about true out-of-pocket costs. We understand that most members may not have any out-of-pocket costs, but there is a requirement to still track the gross drug costs for members in case they transfer out of the plan. Also, coordination of benefits. There are daily updates that CMS sends out if any members have reported if there's other drug coverage reported for the members. There's also the requirement is to review the annual COB file, which we call it. So please be mindful of those requirements. And most of the criteria that we use to review these items are in the PACE manual or the Part D prescription drug manual. And that pretty much concludes my presentation. If you have any questions, you can. We have a general email box. You can email. It's right there on the screen. And if you prefer to have or to address a particular person in our division, there's a couple contact people. Thank you very much.
Okay, if there's any in-house participants who have a question, please move to the mic in the center of the room. It doesn't look like we have any in-house, so I will go to the questions we received from our viewing audience. Now, this first question, there are 3 of them, and they refer to the recent 1/3 CMS 2013 financial audits that many PACE programs recently had in 2015. The first question is, what is the expected action and documentation by PACE programs if they become aware of participants on the COB list for Part D who are listed as having liability or auto no-fault insurance?
Okay, this relates back to the a point I made about please refer to like the PACE manual or the Part D prescription drug manual. PACE plans are required to notify each beneficiary if they have other drug coverage on the COB file, and they need to report back if there's any updates that the member gave to those files.
Okay. Then second question on the topic, do PACE programs need to obtain this list every year and document follow-up on each participant listed?
Yes, the requirement is to review the annual COB file and to determine if any members on there have other drug coverage.
Okay, and the third question on that topic, if we become aware a participant is on the COB list for any of the MSP reasons listed above, are we expected to review all the meds and determine if any are to be covered by the other insurance?
Yes, if there's other drug coverage listed, you are required to coordinate benefits. And
Okay.
we don't get involved with exactly what steps to do when you coordinate benefits, but it's up to the insurance company to do that.
Okay. Next question. Will CMS formalize the audit guide and audit process used to facilitate the PACE 2013 one-third financial audit?
I think this may relate with the other audits that maybe the compliance audit. I think they have a formal audit guide issued out. We do not issue a formal audit guide, but we do have standardized audit procedures and processes that are performed for pretty much all the PACE programs.
Okay. The next question. Please discuss the Medicare payments and what is the specific level of payments for PACE capitations from Medicare?
That one really doesn't relate to the audit, so we'll have to get back to you on that one, yeah.
Okay. All right, and I have one final question here. Our organization was one of the 33 POs that experienced the financial audit for Part D bid fiscal year 15. We were dinged for not having proof of delivery for medication delivery. According to PACE Part D regulations, POs are not required to have this proof. How would you suggest we respond to our auditors about this?
Well, each audit issue is handled on a case-by-case basis. Again, as I mentioned in the presentation, if you have a disagreement with something, please bring it up to us at the exit conference. And then there's also a formal process. You can complete the agree-disagree letter. You can include that. That will be included in the audit report. And then once we receive the audit report, what we do is our compliance unit will review all of the findings and the responses, and we will also involve our subject matter experts and policy experts if there's something that needs to be resolved with any disagreements. So that is the process to take if you have a disagreement with an audit issue.
Okay, and that brings an end to the questions that I have at this time. So I would like to thank Yasmin and Amanda for providing us an understanding of the reporting and audit process.
Yeah, it is. I thought it was more, yeah, I think so. I thought it would be.
Okay, it is that time again for an evaluation. So this is session 6. If you'd like to evaluate it, go ahead and choose A. Follow the link and follow the instructions. We are delighted to have with us our next speaker who will discuss the PACE Innovation Act. From the Medicare-Medicaid Coordination Office, I'd like to introduce Paul Preck.
Hi, I'm Paul Precht. I'm with the Medicare-Medicaid Coordination Office. We are an office in CMS that's charged with improving the care and the coordination of care for people with Medicare and Medicaid. And I'm also acting as a leader of a cross-agency work group that is looking to stand up a demonstration under the PACE Innovation Act. So we are operating under the theory that the PACE model of care, or more precisely an adaptation of the PACE model of care, that is integration and coordination of all medical services and social supports, the interdisciplinary team, person-centered care planning, and full capitation for all Medicare and Medicaid services will result in positive outcomes for new populations not now eligible for PACE. So the PACE Innovation Act was signed into law last November. It authorizes HHS to waive applicable Medicare and Medicaid requirements of PACE to conduct demonstrations under Section 1115 Big A of the Social Security Act. And that means we can newly test models of PACE for those under 55 as well as those who do not meet the qualifications, nursing home level of care, including those over 55. The PACE Innovation Act prohibits us from waiving certain provisions, including the requirement to offer all items and services under Medicare and Medicaid, and certain requirements regarding enrollment and disenrollment. So a word about 1115 Big A. This is the Innovation Center Authority under the Affordable Care Act. It allows the testing of new models to see if they will improve quality and reduce costs, or improve quality while without increasing costs, or reduce costs without compromising quality. And if a model meets any of those three tests, it can be made a permanent part of the Medicare and Medicaid program through regulation. We're here to talk today about what populations we should test the PACE model of care and how we should adopt the PACE model of care to better serve those populations. So I'm taking a little bit of risk here because I'm actually speaking about some things that we don't know and asking for your input, but we'll get to that in a little bit. But first, a little background. Before enactment of the PACE Innovation Act, the President's budget for the last 3 years has included legislative recommendations for authority to test the PACE model for younger populations. So you can see it's been an administration priority for some time. The National PACE Association is working now with disability advocates and providers and has developed an adapted PACE protocol to adapt the PACE model to serve individuals with disabilities, including physical, intellectual, and developmental disabilities. And we've looked at that model, and it's informing our work. And then over the last few years, CMS, in cooperation with the Administration for Community Living, have hosted listening sessions with disability advocates on how to adapt the PACE model to better serve people with disabilities. So one population that's at the top of our list for the broad authority provided under the PACE Innovation Act is Medicare, Medicaid enrollees age 21 or older, meeting a nursing home level of care, and with physical disabilities that impair their mobility. And I'll get into a little bit more in just a few minutes about why it's sort of at the top of our list. But when we think about how to serve this population, guiding our work is how to make the PACE model maximize community integration. And that leads to thinking about the PACE Center and how to modify the PACE Center to better serve this population, and how to apply the concepts from the home and community-based services settings rule to any model. And that means that the settings where people receive community supports, the care that enables them to live in the community, must be integrated with the greater community and must promote that integration. And also, of crucial importance to this population is that they have the ability to self-direct their personal attendant care. And I think I've been neglecting to move my slides. So I will catch up now, and I apologize. So a little bit about this population. Roughly a quarter of the individuals with mobility impairments, Medicare, Medicaid, and meeting a nursing home level of care reside in institutions. And we believe, and the states we've talked to believe, that a meaningful percentage of these individuals could live in the community with the support of PACE-like services. They have high rates of spending, both on the Medicare and the Medicaid side, which indicates the intensity of the services they receive, and which argues for the type of comprehensive, coordinated approach that PACE delivers. Community integration and the quality of life that they have is of utmost importance to the population, and to our mind it means, because that is the overarching goal for PACE, it's a good fit. So when we think about this population, we think that it allows us to retain the core elements of the PACE model in delivering care that's suitable for these individuals. And that includes capitated payments for the delivery of all Medicare and Medicaid services, provision and coordination of care, including the development of a person-centered care plan for medical, behavioral, and social services through an interdisciplinary team, integration of all medical, behavioral, and social services to foster community living and community integration, and joint CMS and state program oversight. But there are potential differences to make the care appropriate for this younger population. Services, and particularly non-medical services, could be provided at alternative locations from a PACE center to provide greater choice and community integration. Innovation in the composition of and the processes used by the interdisciplinary care team. Participating organizations might be encouraged to innovate on the PACE model to provide greater freedom of choice of providers. Many of these individuals will have long-time specialists to treat conditions like multiple sclerosis. They will want to retain access to those providers, and those providers would need to be integrated into the interdisciplinary team. And then there are enhanced social services, employment support services to gain competitive employment that are relevant to the younger population. And because it's a different population and because it's subject to an evaluation under 1115 Big A, there would be additional and different quality measurements that we would need to employ to ensure that we're meeting the goals of the demonstration in terms of improved community integration, satisfaction with the quality of life, and many of the other types of measures that Tamika talked about as well in terms of hospitalizations and those direct care measures. So that's maybe at the top of the list and maybe the cleanest fit. But the authority under the PACE Innovation Act is very broad. And we believe that there are additional populations who could be well served by an adaptation of the PACE model of care. So as I talk about these, I think you will see some of them will resonate with you, and others you may think, well, this is very different from what we do. But there are core elements to the PACE model that would apply to organizations that aren't now PACE organizations. Provider-based model that delivers primary care, that integrates all the care through an interdisciplinary team, and integrates both medical and social services. I mean, that can be a very different type of organization. That's the core of the PACE model. So among the populations I want to mention and raise some of the issues and then have a dialogue with you are younger individuals with intellectual and developmental disabilities, with severe and persistent mental illness, with substance use disorders, with end-stage renal disease, and then among the elderly Medicare beneficiaries, those who are at risk for but not yet assessed as requiring a nursing home level of care. And these populations require more substantial changes to the PACE model. They move further from the core areas of existing PACE organizations' experience in delivering care. They require the development of new eligibility criteria or new ways to pay for care as we talk about more Medicare or Medicaid-only individuals. So intellectual and developmental disabilities. So when we talk about the eligibility criteria, many of these individuals are assessed for what's called an institutional level of care or intermediate care facility. That's different from a nursing home level of care. There are many in the advocacy community who think that's too wide a net, that individuals who are assessed with that level of care may be very healthy from a physical point of view, and that the PACE model is not appropriate to them, that it would be better to combine some sort of institutional level of care with other medical conditions, so we're getting at sort of the sweet spot for care, for PACE in the integration of medical and social services. Community integration is of utmost importance because of the history of some of the care that has been provided to this population, the concern that any adult day center or PACE center would serve to isolate individuals from the broader community. That is anathema to this population and to their advocates. So it really requires rethinking of the role of the PACE center, the role of adult daycare, and greater emphasis on integration into the broader community. The next category that we've talked with a number of states about is individuals with serious mental illness who, I think it's no secret in this society, are not well served by the delivery system. So again, we have to talk about eligibility criteria. If we include a nursing home level of care, are we unduly limiting who would get services? Would we want to include additional medical diagnoses to get to some of the added benefits of PACE by integrating medical and behavioral health? Many of these individuals are Medicaid only, so is there interest among states in sort of paying the full freight in terms of capitation for at least a portion of the enrollees? What's the role of the PACE Center and how do we promote community integration? Can this serve as a alternative to inpatient treatment? Does the PACE Center become more like a drop-in center? So I'm asking a bunch of questions and I'm hoping I'll get some answers. There we go. Substance use disorder. I think there are many of the same issues for individuals with serious mental illness. There's clearly a lot of overlap in the two populations. Is there a role for the PACE Center as a treatment hub? We know that people with end-stage renal disease are now served under PACE, but as we think of a way of targeting this population under a PACE-like model, we might want to think about how to reconfigure the center if people are already spending 3 days a week in a dialysis center. And is there more that they could get there in terms of services? What's the role for Medicaid if individuals don't meet the nursing home level of care? And is there a role in the capitation payments that Medicaid would make to cover the substantial cost sharing for dialysis under Medicare? And so now getting back to sort of where PACE started, the frail elderly. There's been a lot of discussion about the potential to expand PACE if we do something to broaden the criteria beyond the nursing home level of care. So are there diagnoses or ADLs, activities of limitations on activities of daily living that could substitute for that criteria? Would there be any age limits at all? Are we going to be able to better include people with Medicare only or Medicaid only without, prohibitive premiums? Are there changes to how the Part D payments and premiums work that would make access easier for people who are not fully dual eligible? And, if we move away from the nursing home level of care, the big question is, what is Medicaid paying for then if they are not paying, if these are not individuals who are absent PACE wouldn't receive, waiver services or nursing home services? So these are all big questions, but we would like to, begin the dialogue or continue the dialogue with you all about how we can take the PACE model, change it, retain its core in terms of the coordination of care and a provider-based delivery system, but get more people who need it access to it. So I am going to stop there and catch up on my slides with the last slide, which includes my contact information. And I'll just say at the outset, we have authority under the PACE Innovation Act to stand up a demonstration. And under a demonstration, there would be the opportunity for organizations, both PACE organizations and others, to apply. But the PACE Innovation Act does not provide the kind of broad authority to just say, we want to waive our age limits in our organization or waive, statutory requirements. It requires the changing of the model, the changing of the eligibility in the context of a model test. So I'll leave it there.
Okay, we do have time for questions, so if there's anyone who has a question, please move to one of the microphones in the center aisle. We have received a number of questions from the webcast viewers, so I will go ahead and address these questions. The first one is, what possible changes could existing PACE programs see in relation to the Innovation Act?
Okay. So we're hopeful that existing PACE organizations will soon, and I mean that in CMS time, soon have the opportunity to apply to serve populations who are not now eligible for PACE. But as I said, the PACE Innovation Act provides the authority to waive certain existing PACE requirements in the context of a demonstration under 1115 Big A, but it does not provide additional authority to waive PACE requirements outside of a demonstration that is for existing PACE organizations now.
Okay, the next question that we have received. Is CMS accepting applications that include innovations in the area of daycare center alternatives and community physicians?
So we are not accepting applications at this time, but we're interested in ideas and proposals on how we could use our authority in including in these areas. We would expect that a model test, particularly for individuals with disabilities, would address both the use of community physicians as well as daycare center alternatives.
Okay, the next question that we have here. How long before the Innovation Act regulations will be promulgated? Thank you.
So the launch of any model test under the PACE Innovation Act, it wouldn't come through regulations. More typically, model tests under 1115 Big A come through a request for applications. We're working to stand up something as soon as possible, but that's all I can say at this point.
All right. And I have a question here with a number of different parts, so I'm going to go ahead and read it, so bear with me. In developing a pilot for people with disabilities, what is CMS's approach to dealing with potentially different needs and requirements for different types of disabilities? For example, might the needs of people with physical disabilities be different than people with intellectual or developmental disability? Is CMS considering different tracks for the pilot to reflect the different disability subpopulations?
That's an excellent question. So there are core elements to the PACE model. For example, the interdisciplinary team, the provision of all Medicare and Medicaid services that would be the same regardless of the population served. But the needs and preferences, and therefore the way care would be delivered, differ among different populations with disabilities, such as between individuals with physical or intellectual and developmental disabilities. And this would affect the additional services provided, the role of the PACE Center, the composition of the interdisciplinary team. And for those reasons, and because the evaluation of a pilot requires broad commonality in how participating organizations deliver care and in the population they serve, we are considering different tracks for different subpopulations among people with disabilities.
All right, thank you. And those are all the questions that I have for Paul today. So with that, I would like to thank Paul for the discussion on how the PACE model might be adapted to create positive outcomes for new populations. Oh, sorry. We do have one more question.
Okay.
Please promise that I don't have to say that again, though.
Okay, no. I'll just sneak it in. As you're talking, I'm thinking about all the groups in the state where I come from that already do the kind of work, like we have a mental health center that we kind of partner with that does actually have a pharmacy on site, and they also now have incorporated primary care into their thing. It still, I don't think, works as well as PACE does because they don't use that interdisciplinary team approach, I don't think, from my experience with them. But I'm wondering why we would think that we would just extend PACE to these other populations rather than try to extend the PACE model into the groups that are already working with and have the talents and background and education to deal with the chronically mentally ill or the people with intellectual and developmental disabilities. Why don't we bring PACE to them rather than having PACE try to duplicate their efforts or whatever?
So I think that is what we're trying. So we're trying to deliver to provide the PACE model to additional populations. And that could mean a completely non-PACE organization, never been a PACE organization, but it has those core models, the interdisciplinary team, the, capitated payments. I won't go through the whole list. And they could deliver that. And certainly there are groups like that that we know are interested in, providing services under the demonstration. It could also be a PACE organization that wants to partner with an individual, a community group, like you mentioned, that already has the expertise to serve people with behavioral issues, but you bring something to the table too in terms of how the interdisciplinary team works, in terms of primary care, in terms of, home and community-based type services. So there's lots of configurations that we see being possible here. So it is really, when you see this, it is an testing and adaptation of the PACE model, not, just providing, and it's not limited to PACE organizations, although certainly we would hope that you all would, find opportunities when we stand up a demonstration.
Okay. Any more? All right, so would you please help me in thanking Paul today? Okay, so that time again, to evaluate session 7, go ahead and enter A. Follow the link and the instructions. Our next session is what we call an open Q&A session, and this is the opportunity for our presenters to answer any of your questions that we have not answered thus far. So any questions that you may have thought of throughout the day, please bring to the table when that session is up here to answer those questions. And also for our viewing audience, any questions that you have sent in throughout the day or ahead of time that we have not addressed, we will be addressing hopefully during this time. We are going to call up the speakers session by session, and we will start with the very first one, which was quality reporting today and tomorrow. And we will have those speakers come up on stage, and we will invite the in-house audience to ask any additional questions, and also we will ask questions that were received from our viewing audience. We have approximately 3 minutes allotted to each group. Should we need more, we can certainly do that, or if we don't have any more questions for them, we will then move on to the next group. So the first group that we're going to call up is the session quality reporting today and tomorrow with Tamika Gladney, Daniel Diceroth, Gretchen Kane, and Lynn Clark. And I'll start off by inviting anyone in the in-house audience, if you have a question, to step up to the microphone. If you do that, please give us your name and your organization.
Good afternoon, Del Conyers with the National PACE Association. In your presentation earlier, you commented that there will be a change in the guidance that reflects the new quality reporting requirements that will replace level 1 and 2. My question is, will PACE organizations have the opportunity to provide insight on any draft version of that prior to its implementation? We often find ourselves being reactive to guidance documents that are issued, and we are currently in a process, for example, level 1, where we're providing comments to you on some of the operational challenges or issues that have been incurred. So will there be an opportunity to be proactive in providing comments rather than reactive as we've been in the past?
Yeah, thank you for your question. You know, like I said earlier in our presentation, we really want to speak with our PACE organizations directly with all of the changes that we're making. This will include the changes that are coming down the pike. So what we will do is we will try our best to communicate things that are going to be put out, and we will solicit your feedback. Thank you.
So I'm Linda Trowbridge from CEI in Oakland, and I have a question kind of on behalf of our organization and the California PACE organizations, and that is when you begin to publicly report the data, are you in the process of establishing benchmarks and measures, and will there be input into that so that before this is actually reported, people know where they stand?
Yes, ma'am. That's a very good question. The first thing that I must continue to reiterate is that with level 1, we have learned a whole lot about how to collect that data. So in turn, we're really going to have to learn about the data we've collected, and that means really cleaning it before we submit it out. And one of the bigger things that we want to try to do with that data is to kind of share it with other experts and make sure that we have good data that we put out. So to answer your question, yes.
So how will you establish the benchmarks?
That has not been established thus far. However, we will try to stay in communication when that process becomes valid.
Do you think it's in the next 3 months, 4 months, 6 months, a year?
I would not want to say that right now and overpromise.
Okay, and so I'm assuming that even though there's going to be one set of guidance for level 1 and 2, there will still be 2 different kinds of incidents. Are we correct? There will be a level 1 and there'll be a level 2, even though it'll be one set of guiding principles?
It'll actually be all of the elements that we were required to for PACE organizations to submit.
Not sure that really answers the question. Will there be level 1 and where there'll still be level 2?
There will be elements that are required for PACE organizations to submit. Like in our presentation, we said we're moving away from the language, level 1 and level 2, but those elements, those quality elements would still be required to submit.
Thank you.
You're welcome.
Okay, and then I have another question that was received from our viewing audience. And that question is, please clarify removing participant deaths from level 1 reporting as it will be reported as a level 2. The criteria for a level 2 death is homicide or unexpected death.
Yeah, so this change was brought about because we've gotten some comments and feedback from our PACE organizations that deaths in level 1 and deaths in level 2 was kind of similar, so that it kind of looked like it was duplicated. And so when we looked at it, we decided that from the feedback that we received, that we would look to more of the unusual type deaths, since we know this is a frail population, and that that we will experience death in this population. So we really wanted to kind of look for the unusual types of incidences concerning death.
Okay, we have another in-house question.
Anita McClendon with OnLock, sort of piggybacking on Linda's question. So yes, level 1, level 2, we're not going to have a differentiation in terms of what they're called and all the same guidance, but will the reporting requirements be different to differentiate between those two? And there's some confusion about that.
Sorry for the confusion. So let me just give an example. In level 1, we have falls without injury, and in level 2, we have falls with injury. That criteria will basically try to stay the same. However, with feedback from our experts and feedback from our PACE organizations, some of those definitions would just be made more clearer. but the required element would still stay the same.
So Tamika, I'm sorry to interrupt, but there's still going to be different thresholds for the different types of events. So a fall without injury would have one threshold, and a fall with injury would still have a specific threshold. Is that correct?
Yes, yes.
Go ahead with your question.
Hi, I'm Dorothy Ginsburg with Altitude Edge Consulting. So I just want to be clear on how this will work in terms of what is currently level 2 reporting. How will that distinction be made, and how will programs know when to report something and do root cause analysis, et cetera?
So we will have guidances for that, and we will try to clarify it the best we can, like we did previously. And I think the question was asked earlier, will you guys have an opportunity to provide input? We will use all those avenues for getting that information to make the guidances more clearer.
Any additional questions? Okay, go ahead, please.
Hi, Julia Weisner from CEI again. So in your slides, you talk about the new quality reporting guidance coming out. Can you give some more background on when that might be?
I cannot.
All right.
I'm sorry. I want to, but I can't. Let me just explain. A lot of you are asking for deadlines and time frames. It will behoove me to be up here and give you these time frames, and when we don't meet them, that's not fair to you all. It's a lot of work that goes into these guidances. We have to get feedback. We have to get input. It has to be signed off for our leadership. There's a whole entire process that we have to go through. So to give you a time frame would just not be fair. Just note that we are working really hard to try to get you clear guidances. We know that there's a lot of changes coming down the pike. We know that you want to provide your feedback. We want it, we need it. But as far as time frames, it's very difficult for me to sit here and give you one and I know that that's probably not the right thing to do. So, next question, I'm sorry.
Hi, this is Chris Van Reenen from the National PACE Association. Tamika, forgive me, but I thought that I kind of understood what you were saying when you gave your presentation, and I guess in my mind, there was going to be a new kind of overarching umbrella of quality data reporting, but essentially, although they would no longer be called level 1 and level 2, the same data elements would still fall under that umbrella.
That is correct.
With the current thresholds or definitions as it relates to level 1, previously level 1, and thresholds as it relates to level 2.
Yes, with some tweaking for clarification purposes.
Okay, so in terms of the tweaking, we could anticipate that there would be a new PACE quality data document incorporating level 1 and level 2 with tweaks.
I'm going to say yes.
Thank you.
Yes.
And then I have one other question as it relates to the econometrica NQF endorsed measures at the point that they in fact are endorsed. And as it relates to falls and pressure ulcers, is it anticipated then that those NQF endorsed measures, when implemented, and I know it's impossible to give a time frame around those, would replace the current PACE quality data measures related to falls and pressure ulcers?
Well, that's a very valid question. I will say that we do have a PRA package out about that very thing, and that we can't give a comment on it. But I will say that we are definitely concentrating on not trying to duplicate efforts.
Fair enough. Thank you very much.
Yes, ma'am.
Hello, I'm Suzanne Coiner from Centera PACE. Thank you very much for being part of this today and making this available to us. I do have a question. Quality reporting is very, very critical to all of our PACE organizations, and we're excited to have meaningful measures. And now you're working with econometrica. I can't say the word, econometrica.
Yes, ma'am.
So are your account managers aware of those efforts, and if they're doing something maybe as a pilot or they're collecting additional data with the POs in their region, how is that playing into the work that you're doing with that consulting company?
Econometrica has a specific scope of practice, and so we have to keep them within that scope. In CMS, we have our account managers. If they are doing that type of work, we try to communicate that, but because it's a contractual project, we try to keep it a little bit separate, but just be aware of some of the processes that are happening and data collection is happening across CMS.
And a follow-on question, if I may. You know, I think that as we are requested to participate in those pilot programs, for it to be meaningful to us, getting feedback as how we compare in our benchmarking within our region is important. And so I'm not sure other regions are doing that, but I'm just curious as to, is that something that's common across CMS, that there's these individual pilot programs and that data is analyzed, and how is that shared with people who participate in those types of pilots?
That would be specific probably to the region or the account manager.
Okay.
But I would say that, so I don't think that we can universally say that it's shared across all regions.
Okay. Thank you.
Hi, I'm Sharon Boyd with Sutter Senior Care, and I just have a question about when the new PACE regulations are going to be out.
That's an excellent question. And I'm going to say we are working on it, and soon. Yes, ma'am. Thank you for that question. Thank you.
Any additional questions for
No,
quality?
Stacy.
Somehow I knew that was coming. All right, then I would like to thank Tamika and Daniel, Gretchen, and Lynn. Okay, our next session, PACE, a vision for the future. So we're going to have, Tamika was part of that session too, so she's going to stay where she's at, and Mark Stewart and Dr. Christy McNeely are going to join her. Again, I would like to invite anyone in the audience to step to the center to a microphone if you have a question. And I will move forward with asking the questions that we have received from our virtual audience. And the first one is, due to the increasing number of mentally ill participants, as well as those affected by drug and alcoholism, is there any consideration of quality measures around these populations?
Along with our technical expert panel, we kind of get these types of recommendations and suggestions. This also is a good suggestion, and we plan on taking it back to our TEP and discussing it. But thank you.
The second question that I have, may I ask for clarification of definition? 1, living in community. Does that include assisted living?
Yes, and so we're putting the future in this title, and you're sort of seeing the latest development. As it's currently specified, a participant residing in assisted living would not be counted in the percent in nursing home. I need to say that as it's currently drafted and as it moves through the process, there will be an opportunity for public comment.
Okay, and there is a second part to this for the clarification of definition, and this one has to do with depression. Is there a benchmark for comparison? Does depression include anxiety?
So I should have had my first response start with yes, you may ask. And regarding depression, anxiety would not unless it's a concurrent diagnosis with the depression. And again, this is sort of like as of right now, as you can imagine, the measure development and specification happens over time. And we work with the technical expert panel that Tamika mentioned. In addition to the meetings we spoke about earlier, we do have one-on-one conversations with experts, geriatricians, psychiatrists. We've learned much from them. We've also learned a great deal from the site visits that were mentioned earlier. So we're learning things like we need to be agnostic on the form, whether it's the GDS or the PHQ-9. So as of right now, anxiety would not be included.
Okay, thank you. And the last question that I have here. Are participants living in assisted living communities considered living in the community?
Yes. Yes. So Mark just kind of answered this. And yes, as it currently is being developed.
Okay. Any additional questions for Tamika, Mark, or Christy? Oh, we do have one.
This question is for Mark. Perhaps you can shed some light. So with regard to the potential implementation of the measures, will PACE programs be expected to report data, participant-level data, and the aggregate via the data collection sheets, in which case CMS will then compute the measure results, or will the onus be placed on the PACE program to calculate the numerator and denominator and submit that data to CMS?
So if I understand the question correctly, it will be calculated at CMS. The PACE organizations would do the data collection and submission. Implementation is that further stage on the CMS blueprint. And at that point, we will provide technical assistance to CMS as part of implementation.
Okay, great. And just to follow up, in the slides, and it's been mentioned today, we sort of allude to public reporting. Will there be a process in which CMS engages in sort of what the plan will be, an opportunity to provide comment to inform that process?
There is a comment period for implementation. I mean, for these quality measures. So we'll go through that process.
Great, thank you.
Any additional questions? No? Okay, well, please help me to thank Tamika, Mark, and Christy for their participation today.
Thank you.
Okay, I'm going to ask our next group if they would come up these steps over here and then just stand next to me, and I will hand you a microphone. Our next group, the session was called Building a Relationship with Your Account Manager, and we have Commander Amy Hesselgesser, Anne-Marie Anderson, and Marianne Legati. And if you could just stand to my right, and I will hand one of you the microphone. And you have to stand next to each other, not behind. Everyone likes to hide behind me, just because I'm tall. All right. So I would again like to invite anyone in our audience to step forward to the microphone if you have a question. And I did have a question that came in from the viewing audience. Thank you for sending in this question. It is, for some POs, quarterly meetings are not consistently held, leaving a sense that any calls scheduled are for punitive purposes. Wondering how consistent these meetings take place across the region and county.
Country, right?
Country. Okay, thank you.
I'll take that. I wouldn't be able to address the national question that was posed there, but I can tell you that generally those meetings should be occurring. And as part of our presentation today, we talked about being communicative with one another. So my recommendation would be, if you have a situation like that where your calls are you feel like the nature of the call is punitive, that you have an open conversation with your account manager about it. And also, if there's a concern about the periodicity of your calls, that you reach out to them as well. There are a number of things that might impact that, because you know that our account managers do participate in audits as well as being your account manager. So we would just suggest that you be flexible and then have a talk about scheduling so that you can have frequent meetings with one another.
Okay, any additional questions? All right, well, that was the only one that had come in for them, so please help me to thank Amy, Anne-Marie, and Marianne. Okay, moving on to the next session. It is state roles and responsibilities related to PACE eligibility. And we had Cindy Proper and Carrie Smith. If you would like to come up and join me, please. All right, the first question that I have here. During the waiving versus deeming discussion, it was stated that once an enrollee is waived, they no longer have to submit an annual LOC recertification. Does this also pertain to the annual reassessment since they are completed together?
No, no. and it's not a requirement that they be completed together. The annual recertification of continued eligibility is a completely separate process. I recognize some PACE organizations and states like to conduct it during the regular participants' annual assessment just for convenience purposes, because they're already, looking at the plan of care and doing assessments, but that does not negate any of the regular assessment requirements in the PACE regulation as far as annual, semi-annual, whatever. So that's a completely separate process. So the answer is no.
Okay, next question. If a potential enrollee has signed enrollment paperwork but ends up in the hospital prior to the enrollment date, can a PO then deny enrollment?
Do you want me to take this one? They wouldn't deny enrollment, but if it's prior to the effective date of enrollment, the regulation does require that at the time of enrollment, an individual be able to live safely in the community at the time of enrollment. So if a change in condition occurred prior to the effective date of enrollment, the individual would need to be reassessed, potentially after they recovered from that incident, before being enrolled. So. And ultimately, if the PACE organization determined they were not able to live safely in the community, then at that time they would deny enrollment.
Okay. Next question. If a potential enrollee does not have Medicare Part A, B, and Medicaid, how does the PO establish a rate without violating insurance rules and regulations?
Okay, so if someone does not have Medicare or Medicaid, CMS does not have purview of how the rate is set. So it would have to be determined by, like, if there were any rules in the state, like if they were licensed as a managed care organization or something else in the state, then they would have to meet those rules. But in many cases, that's not the case. So we don't have any purview or have any restrictions or actually guidance about how that would be established.
Okay, we have a question from an in-house guest. Go ahead, please.
Hello, my name is Aaron McPherson. I'm from CEI in Oakland. What if we believe that an individual living situation is unsafe, but they could be safe in a different home environment, but they won't move? Can we disenroll them? Or can we deny enrollment? I'm sorry.
Okay, good catch. There are two different things, right? So it's all about establishing a care plan and whether someone, you believe that they would be willing to comply with that care plan, and that's usually part of the as I was saying before, what criteria for living safely in the community, and typically the state will put in there that they are able to comply with their plan of care. So that's the hook I would give you if you have concerns about not being able to serve them appropriately in their current setting. That would be the hook that you would use to be able to deny enrollment. But I would have to say, that organizations can be very creative about helping people work through those situations, and people on the team can be very convincing and work with folks to try to help them understand how they could be better in a different situation.
Thank you.
And I would add, similar to what we talked about the presentation about this would be a perfect example of why it would be a good idea for a PACE organization to offer, an appeal to their enrollment denial, because that might be a situation where you might be denying enrollment because you feel they don't have a safe living environment and you're not able to serve them safely at the time of enrollment. And they could come forward and say, well, do we have other options? Could we find other living arrangements? So, yeah.
Okay. Yeah, I don't want that back. You can keep that. And the last question that I have from our viewing audience, explain nursing facility placement as it relates to continued eligibility in PACE.
So living arrangement doesn't have any impact on the continued eligibility requirement in the reg. It's only at the time of enrollment an individual has to be able to live safely in the community. Once they're enrolled, there's really no reflection on where that person's living. It's just more about do they continue to meet the nursing facility level of care.
Okay, any additional questions for Cindy or Carrie? Now I can have it back. Okay, please help me thank them for their participation today. All right, moving on to our next session, it was change of ownership, or CHOW, and I would like to invite Kelly Ordonio up. All right, if there are no in-house questions, we do have one. Okay, we'll start with the one that we have in-house.
Hi, Chris Van Renen, National PACE Association. Kelly, I have a question in regard to change of ownership when the acquiring organization is not a PACE organization, and specifically around the provider application process.
Yes.
Are state readiness reviews going to be part of that application process? I mean, those would be PACE centers that had already gone through state readiness reviews and annual audits, or is there going to be some modification of the application process in the CHOW context?
Currently, our PACE application process for an entity that is seeking to become a qualified PACE organization will come through the application process as it is. And as we go through that process, we can have the discussion and see if there's any, depending on the current situation and what they're looking to achieve, we can have those discussions.
Okay, thank you.
Yes.
Okay, seeing that there are no other in-house questions, I'll jump to the one sent in. That question is, are there any implications on a change of ownership if the PACE organization is under a cap?
So currently, CMS does have the discretion to look at all the information along with any other information that we're aware of when an PACE organization is seeking to have a transaction approved. So we do take all those pieces of information into consideration when we make that decision.
Okay, any additional questions for Kelly? No? Okay, please help me thank Kelly. All right. Financial considerations. Please step to the center aisle if you have questions for Yasmin Galvez or Armando Virata. Oh, good. We do have a question from one of our in-house guests. Go ahead, please.
This is Martha Shealy from Mercy Life in I'm reading you a question from a virtual participant. I just wanted to go back to clarify the steps that a organization should take when the PACE program knows that a participant is listed on the COB list, and it's not a health insurance. So we know, for example, it's liability or something else. What are those steps that we actually have to take?
I don't think I can remember all of them, but they're in the Part D manual. It's probably a couple pages worth of things. Once you receive that file, briefly, you are supposed to contact the member and determine if the reported liability is correct. And then if it is correct, well, if it isn't correct, then there's no follow-up action. But if it is correct, there is other insurance, I guess you would need to then determine whether you need to coordinate benefits with the other third-party liability insurance.
Okay, thank you. Okay, do we have any additional questions? No? Okay, if not, thank you very much, Yasmin and Amando. And our very last session for the day was PACE Innovation Act. It was an update by Paul Preck. And if you have a question in-house, would you please step to the center mic? And I did not receive any questions from our virtual audience. So Paul's going to stay comfy in the seat up there. But I would still like to invite everyone to join me in thanking him and all of the other speakers for their participation today. All right, so we do have an opportunity for you to evaluate this open Q&A session. So go ahead and take your phones out or go to the Poll EV link and click on A and follow the link. And go ahead and evaluate this session. And as you are doing that, I would just like to let you know that after the webcast, an email will be sent to all participants who are registered for the webcast when the audio and video files, transcripts, presentation slides, and other information are posted. So that will be sent out to let you know that it's all there and available. To obtain your CE credits for today's event, please refer to page 20 in the conference guide, which is also posted on the CTEO site. Oops. One last polling question, and we would like to give you an opportunity to complete the event survey. If you would like to do that now, go ahead and enter A into your text messaging or into the Poll EV link. Click on A and follow the link that is sent to you. It'll take you directly to the survey for today's event. All right, and lastly, you will have another opportunity to complete that survey. That will also come to you, the link will come to you in an email following this event. We would like to thank all of our presenters for their hard work and dedication in preparing for today's event. It is definitely a process that takes a lot of time and effort, so we want to thank them for working with us and volunteering their time. We'd like to also thank all of the participants here in-house. We had a very nice turnout today. It's great to see all of those faces out there and just as many participants viewing online. So thank you for taking the time to join us today for this very important event. And with that, I would like to wish you all a wonderful evening and have a great one. Oh, I forgot to mention, we'll be back tomorrow. This is a 2-day event, so please join us tomorrow morning, 9:30.